everyone. You are listening to ToRAISE Questions Doula podcast. I'm Thérèse Hakoun, and I'm Executive Director of ToLabor, an international doula training and certification program. I'm here today by myself. Melanie actually has to be out of labor at this moment, but we're going to go ahead and let you listen to a conversation we are going to be having with our guest today, Dr. Jodi Brown. I think this is going to be a great discussion with a care provider who actually started out as a doula. And unlike many who, if they follow through into a more primary care provider role, usually it is to a midwife, Jodi has chosen to become an obstetrician. And I just think it'd be great to hear her story. I'm really looking forward to it. But before we get to Jodi, I just want to thank Latched Mama once again for sponsoring our podcast. We are so grateful to their business, Melissa, who runs it, Eric, her husband, and all the people who work for Latched Mama. And so we'd like to recommend strongly that you, yourself, listeners, check out latchmama.com and recommend latchmama.com to your clients. They have wonderful clothing for breastfeeding women, and their styles are comfortable and what would I say? Modern. They're for every person, comes in all different sizes. No matter who you are, I think you will find something that you would find suits you well. They have new styles coming in, and things are always changing. So keep also in touch with them through Facebook, Latched Mama at Facebook, and become part of their community and their dialogue. There's always interesting conversations going on about raising children, about birth, about pregnancy, about the whole breastfeeding time period. And we'd like to remind you to check out ToLabor's calendar for workshops. We always have workshops happening every month and more to come. So stay tuned to the calendar. It is always growing. We'd like to give a shout out to a training that will be happening at the end of April in Santa Cruz, California. We'd love you to consider taking it if you live somewhere in the vicinity. But of course, if you're from outside the area, Santa Cruz, what a place to take a mini vacation to take the training. So check that out. And we will also be in Tulsa, Oklahoma in May, and Chicago in April, and Columbus, Ohio in March. So more to come. As I said, the calendar is constantly being worked on, and new workshops will appear. If you yourself are interested in potentially helping us bring a workshop to your community, please contact Nicole, our workshop coordinator, at tolaborworkshops@gmail.com, and she'll have a conversation with you about what is entailed and see if that is a potential. We'd love to serve many different areas that we have not been to in a while or before. So we hope that you'll make it to a training one way or the other. So in a moment, I'll be back and we'll start our conversation with Jodi Brown. Thanks, everyone. Main Body, episode 98. So everyone, we're back, and I'm here with Jodi Brown, Dr. Jodi Brown. Hi, Jodi.
Hi, Thérèse.
How are you doing?
I'm doing well, thank you. Thanks for having me on your podcast.
Oh, thank you for taking time out of, I'm sure, a busy day, busy life to be able to talk to us. In the introduction, prior to talking to you just a moment ago, I was letting our listeners know that we were going to be talking with you, and that, what you're kind of that unique person, at least from my perspective, and it may exist out there people that I'm obviously not aware of, but I thought this would be just such a great conversation to have with you specifically, that you were once a doula and now you are a physician who is actually an obstetrician that works with women in birth, and how you came to be the doula, and then your transition into this other world that we have all encountered in our work. And just, I thought it would be wonderful from all perspectives to hear this. So thanks so much for taking the time.
Absolutely. My pleasure.
So to give people a little background about yourself, can you fill us in, like where you live, what your practice is, maybe family, so forth?
Sure. So right now I live in rural Vermont, Middlebury, Vermont, where I work in a hospital-based practice where I work with 2 other OBGYNs and 2 nurse midwives. And it's a critical access hospital. We have a beautiful birth center where we have 6 women's beds that are available. And this has been a year and a half that I've been working in this practice since I finished with my residency training. And I recently had a child of my own who's now 13 months.
Wow.
A little girl named Liv.
Great. And so tell us a little bit then from the very beginning about your decision first to become a doula. What inspired you? When did you decide to become a doula? How long ago was that?
It was back in 2002 that I went through my doula training, actually with you, in Boston. So I was a senior in college at that time, and I had been working at the Women's Center on my college campus. We had reopened the Women's Center. We were doing a lot of women's health, a lot of activism within the community and on campus. And I had been working as, or had been studying pre-med in addition to being a women's studies major. And so when I heard that there was this thing called being a doula, that you could be there advocating for women, that it had this kind of activist sort of foundation to it, and that it was all about women's health, I was like, yeah, sign me up. This sounds like the perfect thing. I didn't know this was a thing, but now that I know, I'm going to be one. And so I somehow found about the doula training program that you were running, and I signed up, and it was transformative. It was, I think, one of the greatest events of my life that definitely put me on a definite path career-wise that I would not be on today had I not met you back in 2002. So 14 years ago?
Wow.
15 years ago?
15, yeah. Wow.
Yeah, 15 years.
And what, just briefly, and it's not, I don't want to talk about me, what about the workshop? What about that training that, I'm curious, and I think our listeners would be as well. What about it was transformative? I mean, if you were already working and maybe you don't remember, and maybe it's not words, but if there is, like, you were already working in women's health, you were on that, like you said, pre-med path. What was it about that? Anything come to your memory?
Yeah, I think it was mostly that birth was not even in my stream of consciousness as a college student, because, so much of the energy was put forth into preventing birth.
Right.
And that was like the bulk of kind of my focus until I was aware that it was such a social issue and that it was a feminist issue, and how women were birthing or being forced to birth because of their lack of options, or just because of the general medicalization of childbirth up until where we were in our culture, and still kind of coming back from. So that was I think just learning more about birth and how profound an experience was, and to sit in a room full of women, most of which who had been pregnant and gone through childbirth, and listening to their stories and learning about other people and watching videos about people giving birth, to realize what a significant and transformative event childbirth can be, and that it is an incredible rite of passage that many women go through, and that if it's not being honored and respected in the way that many people have seen, especially throughout the history of childbirth in the U.S. and other places in the world, that can have incredible harm, and that it can also severely impact how women regard themselves as their ability to parent, to be mothers, to be women in the world. But it also has this profound opportunity to, I think, empower and inspire women to know what it is that they can go through, and what they can survive and endure, and be empowered to kind of embrace that experience as something that sets them off in their journey to motherhood, and a whole new transition into their life.
And I can imagine, that's beautifully said. I can imagine also as a college student, so you were about 21, 22 years old, somewhere in that, between 20, 22. And like you said, you're involved in women's health issues, but it's more on the other end of the spectrum of keeping women healthy and helping them not to have the pregnancy, if that's, help them from getting pregnant, to have your eyes opened. Everybody, I think there isn't anybody who doesn't stop and think about, baby being born, like, it must be transformative in the sense of, you become a parent, you have a child, but it's more of that's it. It's not delving into what is it that got that person through the pregnancy, the labor, the birth, that informs them to be that parent later on, and how they're treated. Suddenly, I think, is what I hear from people is becomes significant. It's like, I never thought about that before. I didn't, we don't delve into that as a culture, at least in the bigger sense, we don't. It's always the most obvious, that healthy baby, that healthy mother. We all want that. But that's always said in with the parameter that of more physically, not taking in the whole mind, body, spirit of the woman and the baby. So here you are, you take the doula training. Did you start attending births? What did you do?
I did. So, initially I was still had to finish my college degree, and so I got involved with the Cambridge Birth Center in Cambridge, Massachusetts, and was able to work with the doula coordinator there. And it was this fabulous birth center, which I believe is a still functioning birth center. And
I think it is.
Yeah, but they had this multicultural, multilingual doula program where they were taking women from the communities, training them to be doulas, and then providing both interpretive support and labor support for pregnant mamas. And so I got to work in that birth center with the doula coordinator and see how they functioned, and learn kind of how it works from the administrative side of things, and some of the frustrations and the barriers that they were dealing with. And then after that experience, and then after I finished school, I got a doula job working out of, it was Brigham and Women's Hospital and Mass General, and it was part of the study about the effects of doulas on labor.
I remember. I remember when they were doing that. Yes.
Mm-hmm. And so I worked for a year doing that study and being a doula in that capacity.
And that experience, were you meeting people prior to going into labor, or was it all once they were in labor?
Yeah, unfortunately, there was no prenatal contact because we were in a call pool, and so there was no assignment of who you knew you were going to be with. So it was very much on the fly.
And what was that like? I mean, meeting somebody, knowing all that you might have garnered as far as information through the workshop, through the learning that you did then on your own. What was it like to meet people just then in labor with no real ability to know what their desire was before, what their education was? I mean, I'm assuming that was the case.
Yeah. I mean, it was difficult. Now, I was fortunate in that most of the folks who I was able to be a doula for came in early labor. So there was, some time to kind of establish a rapport in the beginning, but you're already, set up at a disadvantage, not knowing anything about them and trying to kind of get to know them between contractions, but also allowing space for them to labor and not, inundate them with chit chat.
Right.
So it was a challenge for sure. And I was also, I feel like looking back on it, like very naive and unseasoned at that time, just, having graduated college and having little experience in the workforce and working with patients that, I'm not sure how effective I was, but I definitely think maybe I got more out of the experience than the people who I was douling for. But it was an eye opener, and it was a great experience. I mean, for me personally, to be there, trying to support women who were attempting to have, unmedicated birth.
And so was that? I mean, see, I feel like, Jodi, that perhaps you did learn so much from those people and those experiences. I have no doubt about that, and about the whole system of care probably being a part of that in that way. But I have very little doubt, because this is my belief system, that if you go in to a birth, whether you have any prior history with them or, ideally it should be better, obviously, if you have prior history, but even if it's at that moment, that if your intention is there to support them and give them whatever options and choices you can as they arise, that, or just even be that focus on them, knowing that that's what your whole purpose in that room is, to be there for them. I just believe it does make it a better birth experience for those people, regardless of what the outcome is. I mean, don't you think that people, I would bet that the feedback still was so positive from those people, from you being there.
Yeah. And I mean, now having this perspective from the other side of things, sometimes it's just about people showing up and being present and being there.
Yeah.
And sometimes, and you don't need to say a word. Right. That is all that is needed. And so it's interesting to kind of think back on those experiences I had, a decade and a half ago at this point.
Right.
I kind of ponder those and what kind of effect or not effect that I had.
Well, I do think it's really an important aspect of the work that a doula does is what you just said, just showing up and being present. I mean, we want them to have all their options and choices. We want them to come in as best prepared as possible. We want to know what their likes, their dislikes, their emotional components, and all of those things. But I do think in the end, you do that. You do that. And even if you didn't open your mouth the whole time, if you made eye contact, if you made some physical contact with that person, I just still believe, and have continuity of care with them. I just think that's the bigger picture overall, is creating that safe space for that person. And it sounds like that was the role of the doula in many ways that you were experiencing. So you did that for a year. Did you do any births outside of that?
No, I just did that, the study. The working study primarily.
And then what happened after that?
And then I relocated to Maine and got a full-time regular work as a medical assistant for a multidisciplinary medical facility, and wasn't able to have the on-call hours of a doula despite my desire to do so. So then I switched gears and taught hypnobirthing for childbirth education, so I could keep my toe in the birth world. Even though I wasn't able to be on call and attend births, I was able to kind of be part of it in that other way, doing teaching with hypnobirthing. Which
is great. I mean, birth work is birth work is birth work. And helping people learn, and then in your choosing the hypnobirthing, giving a skill also in that way is huge. It
was phenomenal. I am so grateful for my experience, having learned how to do hypnobirthing, how to teach hypnobirthing. It really is such a phenomenal way to prepare for birth, and it gives us a whole other kind of perspective and way to approach pregnancy and childbirth.
And I guess that by that, also by being a childbirth educator, you were then able to be part of the birth world, in the sense of you must have known who were the doulas in your area, and who were which hospital or doctors or midwives and such that you felt were good options for people you were working with.
Some.
And so you were, how long were you doing that?
I did that for 2 or 3 years in living in Maine, and then I was able to continue teaching some through medical school as well.
Wow. And I do remember that you helped also bring a doula training up to Maine during that period of time, which again was just another way of doing birth work, is helping give birth, helping create that space for other doulas to be born into it, which is, I remember I had somebody I taught many years ago in New Hampshire who realized she could no longer be a doula because of family life, but she became a regular sponsor of workshops because she felt like, well, this is my way. I can do this. I can put it out there and help create more doulas to fill the void that I can't fill, and which I think is a beautiful way of doing it as well. So somewhere along this line, you were coming to decisions, obviously, about your pathway. And so what was evolving?
I'm sorry, can you repeat that?
Sure. Somewhere in these years that you were, doing the volunteer, or working through the hospital, and then being in Maine, you were making decisions about where to go next in your life, because we know that eventually you became an obstetrician. What was transpiring? What was the motivation, and why an obstetrician and not a midwife, which my experience has been massive in the amount of doulas that I have taught who are on the pathway to becoming midwives or who became midwives.
It had always been my intention to go to medical school, and I prepared for it as an undergrad, and then I took intentional time off to work and live and have other experiences, because once you enter the field of medicine, from the physician side of things, it's really hard to go back from that. And so I wanted to have other experiences doing other things in the medical field that was not being a physician, to make sure that I was committed and prepared to go ahead with it, because once you do it, it's full steam ahead. And so I took 4 wonderful years off between undergrad and going back to medical school, where I was, working in some capacity in the medical field. I was a medical assistant in several different offices, the doula, and then the childbirth educator. And then when I was accepted, I was very much ready to go back. And one of the reasons that I decided to go to medical school as opposed to midwifery school is that I wanted to be the one to make the decisions. I did not want to have somebody else above me saying, no, you can't do that. And even though in general, you still have to follow guidelines. Even when you are a physician, you can't be a lone wolf out there. There's still guidelines that are recommended that you follow for safe practices. But unlike a mid-level provider, like a nurse midwife or a physician assistant or a nurse practitioner, I don't have somebody else standing over me telling me what decisions that I need to make for my patients. And that is ultimately why I decided to proceed with medical school as opposed to doing the midwifery route.
Which I think, can I interrupt you real quick?
Absolutely.
I think that makes total sense to me, what you're saying, because it's the hierarchy. I mean, I hear what you're saying. There's guidelines for you as a practitioner, obviously. But in the end, if the certified nurse midwife has an issue with a birth, in most circumstances, she's going to have to refer or collaborate with, or whatever the case might be, with an obstetrician, and so you're going right straight to that. The difference, I guess, and you can fill in here or have no say about this. The route, so many of the doulas also, I have taught doulas who become CNMs, and I have taught doulas who become CPMs. And though you said your intention always was to go to medical school, was there ever a thought like, well, but I could be that primary care provider if I went the route of a CPM?
I didn't even necessarily entertain being the CPM, and I think it's and part of it is that I've always been somebody who has liked school and done fairly well in school, and I know that is not necessarily the case for all people. And so part of the other reason that I decided to go to medical school is that I felt that I had the capacity to do it, and that I could provide a voice for the people who did not have the capacity to do that, because it is a long and hard road and takes a lot of dedication and a lot of work, and I felt that I had the stamina in me to do it, and that I wanted to do it so that I could also provide a voice for midwives, for the home birth midwives, who otherwise might not have an advocate, or might not have people or physicians who could recognize that they have talents and they have contributions to the birth world, even though they are not themselves physicians.
I think, Jodi, I remember when I knew you were going to become an obstetrician, and that is what I remember feeling like. This will be a woman who will help in the hierarchy. I mean, you are at the top of that ladder, who will be a spokesperson, who will remember what this is about, who will bring that forward into practice. And I'm so glad to hear you articulate that. I mean, I had very little doubt. I think we talked about it as well, but it's like when I know people who are struggling with being a nurse, who have done doula work or taken the training, or just have an awareness of it from their own personal understandings of struggling, not wanting to be a nurse any longer, but stay being a nurse because that's where they belong, or somebody who does decide to become a CNM when they could be and work within the hospital, whereas their heart might be more towards being a CPM. I want to support those people. Not that I'm not supporting people who don't do that, who work outside the system. Totally support that. But when it does take people inside the system to change the system as well. So I think it takes, and I like what you said there. Like for me, going to medical school, not even a possibility. Like not who I am. Not academically, nor that kind of stamina. Like you said, I probably have the stamina, but I wouldn't get through the academic aspect of it. So I think I hear what you're saying is you saw, it's almost like you understood the privilege that you had to be able to do that. And
it's a huge privilege.
Yeah, and that you were going to take that responsibility on. And I really appreciate that.
Well, I'm glad to be that person, and it's after, I think I figured out like 16 or 17 years, 16 years of working towards it. I am now like a year and a half into actually doing it, which is pretty amazing.
Yeah, it is pretty amazing. So when you were deciding on where you wanted to go to school, what were you looking at as far as coming from that background? What was your criteria? And if you don't mind sharing, where did you go to school?
Sure. I ended up doing medical school at Arizona College of Osteopathic Medicine. So I am a doctor of osteopathic medicine, or a DO. And I struggled with it for quite a time about whether or not I was going to go the MD route or the DO route, as I had two really great options. And it's funny enough, it was almost the University of Vermont, where, close to where I live now, that I almost went to medical school. And in the end, I decided that I wanted to be an osteopath because of the holistic approach, or the holistic philosophy that osteopaths scout. So they have, several tenets, which I'll see if I can remember because it's been a while, about kind of the philosophy of osteopathy, one of which is the interconnection of mind, body, spirit, and that physical function and anatomic function are directly related, and that the focus is really on restoring health as opposed to treating disease.
Right.
And so the great thing about osteopathic medical school is that you learn all of the same things that you learn in any medical school, but you also learn how to have hands-on, and you learn how to manipulate and touch people therapeutically, and to provide adjustments to their body. And so it's just an extra tool in your toolkit that you can pull out and use at any time. Okay.
Yeah, that sounds ideal to me for what I said earlier, which is that healthy baby, healthy mama statement is then you're coming from the whole mind, body, and spirit right from your training. And so,
it's a pretty perfect match.
So your schooling was those 4 years out there in Arizona, and did you have doubts, just curious, about following through with this, or was it clear still to you?
It was clear. I mean, the first 2 years is classroom work where, one of the analogies is that it's trying to drink from a fire hose. There's just tons of information just being flooded at you that you just need to memorize and regurgitate and somehow retain pieces of it for the next phase. And so the first 2 years were very kind of overwhelming with schoolwork. And then the second 2 years was getting to experience a little bit of every rotation of every different kind of brand of medicine that there is. And OBGYN was my very first rotation that I did as a third-year medical student. And that was all it took to confirm. I went in pretty sure that I wanted to do OBGYN. I did that rotation, and I was like, yep, well, this is what I will do.
Well, good.
Just confirmed it.
That's good.
Yeah.
Was there ever a temptation with any of the other ones? Like you thought, oh, I do love OBGYN, but I like this as well?
I briefly flirted with the idea of primary care, family medicine, and doing women's health on top of that.
Mm-hmm.
And I really, really loved psychiatry. I thought it was fascinating. I loved getting to talk with people all day. But I think in the end OBGYN was my clear front runner.
That's good.
Well, I was definitely going to do it. Just the passion was there, and the others were, slight interests.
Got it.
But,
Got it.
Ultimately, OB won.
And so then you finished up out there, which this New England girl out in Phoenix must have been torturous at times.
Yeah. It was good for 4 years. Yeah. It was great.
Yeah. And then you came back across the country, correct, and went to into residency. Was that? Did you? I know somewhat about the residency. Yeah, how you go in, you're choosing and so forth, and how you get picked. Were you intentionally looking for certain schools? I would assume that you wanted to be or hospital residency programs that you wanted to be a part of. Yeah,
so it's hard to even remember what exactly the right criteria was, but I was matching with my partner at the time, now husband, who was going into family medicine. So we were trying to negotiate programs that he liked and that I liked, and were also areas of the country we would want to potentially live in. And then we're also trying to find places that were somewhat close to family or people that we knew. And so by the luck of the draw, we ended up in Delaware, where most of my family was living at the time.
Wow.
Yeah. And so we went through the Christiana Care hospital system, the two of us.
So you acquired a soon-to-be husband in your pathway as well. That's pretty good. That's pretty wonderful. Yeah. That's lovely. And so can you talk about your residency a little bit, especially the actual OB experience? Like, was that your first year?
Yeah, so my very first year was very overwhelming, as I think anybody who's been through a residency can tell you, because you go from being a medical student who is, basically following people around, trying to learn, trying to absorb, learning a lot, but not getting to necessarily do a lot. You basically have no power or say. You are there to observe and to learn and to help in whatever way you can. And then you graduate, and all of a sudden you are a physician. And then you are basically thrown into this scenario where you say, okay, you are now managing these people, make this happen. And so that can be very overwhelming, feeling the weight of that responsibility. And certainly there is oversight. You are never by yourself as a brand new intern, and that you have more senior residents who are guiding you and teaching you. But the volume of work that you have as a resident is can be very overwhelming at times. It was often, 70 to 80 hour work weeks that you're working. So you're just working on a baseline level of exhaustion with no time off. And in your free time, you're trying to read and stay current and, read the guidelines and read the textbooks and, trying to stay prepared for, all the patients that you're encountering. And the OB aspect was very difficult. The rotation that I had, where I was the intern managing the labor and delivery unit, I pretty much came home and cried pretty much every day. And just from
from what?
Just watching woman after woman after woman be disempowered, being placed on a clock, setting them up for expectations that they would not meet with in terms of cervical dilation, and that being the end-all be-all. Seeing a lot of C-sections, lots and lots of C-sections for women who, if you had given them time and space, mostly just time, to allow to labor into birth that they could have done. And it's this fine balance, which even, now that I'm talking about it and it's being recorded, it still gives me pause, because I wouldn't want anybody coming in and questioning my judgment about the management of the patients that I care for. And so it's even hard to kind of to question somebody else's judgment in a public way, as I'm talking to you.
I understand.
So,
I understand.
I don't want to, nobody that I worked with, and I worked with some amazing, talented doctors that, I'm very grateful for, who were able to teach me what I needed to know so that I can function today. I know that no one functions out of malice.
Right.
I don't think any of it is from a malicious intent, but I think there's some old school versions of thinking and how people were trained, and people who were of a certain generation were trained about the Friedman curve, and that if you are not on the Friedman curve, you get a C-section.
And so
because you're falling off the curve.
Right. And I think
it's a different kind of way of approaching it. And now certainly there's new guidelines that came out when I was in residency about preventing the first C-section. So now there is much more advocating for giving time and for being patient to prevent the C-sections rate from becoming as, or staying as astronomical as it has become.
And, Jodi, just to interject here, I totally understand I believe I understand what you were bringing up about the lack of malice. I mean, this is something, if you vaguely remember anything about the training you took, that's one of the things we really talk about, is that it's not, we know that there are some misogynists out there. There are some people who are just not kind and should not be doing the work that they're doing. But overall, the people are doing what they believe is the right thing based on the system of care and the way they have been taught, and the way the system has been taught, set up along those teachings, and everybody's just caught in that wheel. So I appreciate that you are not trying to bash in any way your facility, the facility that you were in, nor the style that you were taught through. I believe our listeners will understand that, and I'm putting it out there to understand that. I just appreciate your honesty around it. What I would like to ask you, with that understanding, since you said, it was really hard, and you came home and you cried often, and I'm sure that was also just from sheer exhaustion. You must have been like a raw person. How, though, from the perspective, I mean, I can't help but think how hard it must have been, harder for you in many ways than other residents, that because you did have this background knowledge of what birth could look like, what the purpose, the amount of time. I mean, was that the rawness for you? That feeling? Is that where it would come from? Yeah,
that is part of it. Certainly, is coming from this different perspective of really believing in vaginal birth, and that vaginal birth can happen, and really believing in the inherent ability of a woman's body to give birth like it does every other thing in the world, just kind of functioning on a day-to-day basis. Why would this day necessarily be different, and that it would break down in its ability to function or to work? And so just coming from that perspective of believing that a woman's body was functional and capable, and that also very strongly believing that birth matters. It matters the way that we approach people, and in the way that women give birth and how they're treated around the time that they're giving birth, because those women are going to remember that day for the rest of their life. And so it might just be another day for us of work, but it is everything to that woman and to her family. And so, there was, a lot of interventions, a lot of medicalization of things, and part of it is learning. When you are in a residency in your training, you also need to acquire all the skills, but you also do not have the ability to make independent choices because there's oversight. And so, as an intern specifically, you are practicing and you are functioning how your chief resident functions and practices.
So
because you don't get to make decisions on your own. You are basically the foot soldier. You are executing the decisions that are being made.
God, how hard.
And so to then have to make take action, whether or not I believe that was the correct action or the action that I wanted to take, that was what I then needed to do.
How hard that must have been to be in that conscious place and then have just what you described, having to go ahead. Were there times, though, that you were able, do you think, to make that change or have, input, or just, I just would assume, before you answer that, I just would assume, given who you are and your background, that your empathy towards this or your compassion towards that person, I think, would always still make a difference. And I would imagine you explained things more than maybe had it not been you that was there.
Oh, absolutely. I still do. I explain the heck out of everything I do before I do it, because I wholeheartely believe in informed consent. And for some reason, around the time of labor and birth, for so many people, consent goes out the window. People just do things to women because they think that's just what they do. So they will break their bag of water. They will put in fetal electrodes. They'll put in, intrauterine pressure catheters. They'll give the medication without fully explaining the risks and the benefits. That was part of my disobedience, was to fully explain everything, the pros and the cons, and then say, this is your choice, this is your body, this is your baby, this is what's being recommended. What do you want? What are you okay with?
Which is the work of a doula that we have no control over, but that filling in the void. But, can you take a moment, and this is something that I think could be beneficial, and maybe you can or can't answer this. When we have this discussion during trainings, for instance, about how I know it's not, we hope it's not so common, but we know it's not uncommon for a scenario just like you pointed out, that for instance, the bag of water could be broken and the electrodes could be placed on the baby's head. And then after the fact, after it's done, the provider might say, okay, we've just broken your bag of water and we've put on the internal fetal monitor on the baby's scalp. The question always comes to me from the participants in the trainings is, well, how can that be? How can they do something without not asking permission first? So I have what I think is the answer. How is that possible? I mean, you may do it a different way. You, like you said, you explain everything. You give them the risks, the benefits, their option also to decline besides consent. How can another doctor get away with that, since informed consent that is a patient right?
I think part of it is just the state of what it is to be a laboring woman. You are not in your critical thinking mind, and someone has just asked to put their fingers inside you, and then they just ask for things and they do them. And it's hard to be disempowered as a woman, as a patient, to be there with a physician who on the power dynamic, that's an unequal footing, who is then just doing things. It takes a lot of gumption to say, no, get your hand out of me, get your fingers out of me, don't do that. And certainly I've had patients who, have said, take your fingers out of me, and I obey, because otherwise, that's assault.
Right. I guess maybe maybe you misunderstood me. I'm not questioning how the woman allows it to happen. I'm questioning how can the care provider get away with not first saying, I am considering breaking your bag of water so that we can insert this internal fetal monitor on your baby's scalp, and this is how it's done, and here are the risks and benefits, and you have a right to make a decision. How is it that they can just go ahead and do it without that person's consent?
Well, part of it, I think, is just that they have made their mind, and sometimes it's just informing them of the choice that they have made of going in and being like, all right, I'm going to start Pitocin now. You need Pitocin. Pitocin has started. Or we need to break your bag of water. And it could be framed in like, this is what needs to happen for, labor. This is what needs to happen for the health of your baby. And so it's, when it's framed, certainly in, even when it's in,
it's more of a directive than it is an option.
Yeah, it's a directive. It's more of like, I have made up my mind. This is what I see is the natural course of how things need to go, and I'm going to do that now. And it's more of a not asking for permission, but more of a, this is the decision that I've made.
Right.
Any questions? And
I think also what I've have come to understand, as well as how they get away with it, how that is done legally. And I want to put in there, I think there isn't always an intent to cause harm. I think it's just a practice of, this is what we do. It's more like, that's how they were trained, or this is their personality. This is part of their MO on how they see themselves, and not that they're going in and intentionally, like, I think I'll be sneaky and I'll do this and I'll tell you about it later. Though those people, again, do exist. I have been told that when a patient, a woman in this case, or a pregnant laboring person, when they sign the informed consent form, part of the phrasing in there is that they are giving the physician and the hospital to do what they feel is medically needed, right, just for the circumstances. And so that, in essence, they don't have to ask permission for that breaking of the bag of water, for instance, because you already gave them permission to do what they felt was right. Do you think that's valid? I mean, do you think that's valid? Not that that's the way it is, that is valid. Yes. Yeah, that's why they come from that place, like, as well.
I mean, it certainly could be. And I do remember, going over consent forms for delivery, when I was in training. It was like, sign this piece of paper. It gives us permission to do any and all things that we see fit, which could include, placing scalp electrodes, doing blood transfusions in the event of emergency, or doing an emergency cesarean section if, your life or your baby's life's in danger.
Right.
And so I think for certain things, it certainly, I think is effective. So in the case of an emergency cesarean delivery, if truly, the life of mom and baby is in jeopardy, you need to be able to act quickly, and you don't have time to go through the entire consent. And so, certainly I think doing an abbreviated, this is what's happening and this is why I'm doing it, is always
definitely warranted.
But, sometimes there's not time for the entire conversation to take place. And maybe that's where the kind of catch-all consent form was born. And maybe it has given people the license to feel like they can act in all manners and do all things, because they have this piece of paper saying, well, you consented for all of these things, so I just assumed it was part of that.
I tend to think, Jodi, that does play into consciously, unconsciously, how it comes to play, at least legally in the end, because this is an ongoing question. Well, how could they have done that legally without consent? And I think there's kind of a universal consent that is given. I know it's specific, but it's also does say what the ones that I have read, what the care provider sees is necessary at the time. In legalese, not in my words. But I so appreciate that you and so many other care providers will go to the place that we really all deserve, which is explain to me what you're going to do, of course within time constraints, but under non-emergency situations and here are the risks, the benefits, the options that you have, and you do have the right for informed dissent as well. Like, you don't have to agree. Have you run into situations with patients where they were really stuck in the no, and you're thinking, no, you really need this, or you know that they really need this?
Certainly there's been some, I think more so in my practice here.
Mm-hmm.
Ultimately, I feel like if you counsel somebody appropriately and you counsel them thoroughly and they are fully aware of what the risks and the benefits are, who am I to say, even though I think this is what they need, that is what needs to happen, because ultimately they are living in that body. They are taking care of their baby. I am only going to be in their lives for a blip of time. And ultimately I feel like I can bring my knowledge and my expertise. But when it comes down to it, they have ultimate control and say over what they want for themselves. And I feel like as long as it's coming from a place of knowledge and that they've received all of the information, that, who am I to place judgment on what they see is best for them and their family.
Right. Well, and I think that's true of the role that I've played as an assistant at birth as well. And I'm not the primary care provider in any stretch of the imagination, but it's that, yes, truly informed understanding. And in the end, the decision does lie with that patient, with that person, with their own lifelong experience as a result of those decisions. It's not for me to decide, but I like hearing a doctor say it, being you, to reiterate that. So I think, so that this won't go on too long, I think what might be a great idea is if we pause here, and we'll continue this conversation next week with you, if that's okay, Jodi. So everyone who's listening, please know that we will finish up part 2 next week. Thanks for listening.